Good evening. My name is Jim Wilson, and welcome to the fourth of 10 webinars on the science, policy, medicine, and politics of the COVID-19 pandemic. I'm currently a faculty member at the Perlman School of Medicine at the University of Pennsylvania. I'm also a proud alum of Albion College, and this webinar series is being sponsored by the Lisa and James Institute of Medicine at Albion College. Before we get started, I'd like to review the format for our webinar. After our featured speaker makes some introductory comments, I will introduce 4 students from Albion who will lead a discussion with our speaker. We will also invite from the audience questions that I can see and I will pass along. So really looking forward to this evening, and a pleasure and an honor to have Fritz Francois join us, who currently is the Chief Medical Officer at NYU. Fritz emigrated to the US in his childhood from Haiti and began his education at NYU and has been a lifer. He was an undergraduate there, getting a degree in philosophy, and then went on to medical school, receiving his MD, did his medical residency and GI fellowship. Fritz has taken on this leadership position at NYU that really put him in the crosshairs of the pandemic, and has been involved in many levels. In fact, in April was asked to visit with the president with 14 other hospital representatives to talk about the shortage of ventilators. It seems like forever, but we still have so much ahead of us. So without further ado, I'm going to pass it over to Fritz, and he's going to make some comments before we bring on the students.
Well, thank you so much, and for it's a real pleasure actually to join you and the audience, and to reflect on what has happened over the past few months with the pandemic. But it really does give me an opportunity to think about how we got here, and to understand it. I have to go back and share with you where we are, where we were actually as an organization, even in 2019, and how and what happened during that time. In fact, we probably should go back further and to understand the evolution of how we think about preparedness and resiliency. What stands out in my mind is it goes back to 2012 with Hurricane Sandy, and at that time the hospital really was at an interesting point in its history, because for the very first time it was closed. We had to evacuate all the patients. The school was closed. The research mission was also shut down, and near us, actually in New York, we have not only the Tisch Hospital, we have a public hospital, Bellevue, and we also have a VA hospital going from 23rd Street to 33rd Street on First Avenue. All 3 were closed. We frankly weren't prepared for what happened. And there was a lot of concerns that from others that we would not be able to open our doors again, but we did, and in fairly record time, in terms of making sure that we had the infrastructure to keep everyone safe. Now, once we were able to do that, we thought about how, the way in which we would now start preparing for any other type of unexpected events. And one of the key things that we did was to develop a group actually for emergency management and enterprise resilience. And that particular department then did various assessments at various time points to think about what could happen and how would we prepare if something actually were to happen. And so over the years, once that department actually was in place, we would do tabletop exercises, and we would basically develop these plans just in case. And they included, of course, a hurricane plan. What if another hurricane actually was even bigger than Hurricane Sandy actually came by? How would we handle that? What would we do? And we had one actually for an active shooter exercise. We had a mass casualty exercise. The reason I'm sharing this with you is because leading up to the fall of 2019, the plan, I got a call actually, and the plan actually was to do a tabletop exercise about a coronavirus, believe it or not. This was in probably early December, early to mid-December, before anybody had heard about anything about what was going on in Wuhan. And the only reason actually that we did not move ahead actually with the tabletop exercise at that time is because of my schedule, along with our director of infection disease, infection prevention and control. And we decided that we were going to do it right at the start of the new year in 2020. But the plan was exactly what, as I described, was that the idea was that there's some sort of a outbreak of a coronavirus. We chose MERS as the case, and we wanted to test whether the organization was prepared. What would we do? And we went through this particular scenario to see all the different areas of the organization, and what would this individual do, like where we would put his patients, how would we respond, etc. So leading up to the exercise, which was planned for January 8th, I sat down with Dr. Mike Phillips, who leads the infection prevention and control. And at that point, after the new year, I heard, both of us actually had heard about the news of something going on actually in Wuhan. And we actually commented on it right before this particular session. We thought, this is something that we have to keep an eye on. And we went ahead actually with this particular exercise, which took place on January 8th. And what was incredible about it is that we went through the scenario, again, with the idea that, well, where would we place patients actually who are coming in? How would we keep staff safe? What would we do in terms of other operations? How do we, how we move patients actually from the emergency room, et cetera, and all the various details. And we challenge each other. And it was some really difficult questions as far as, supplies and patient movement and operations, et cetera. Following that particular meeting, we left with some ideas about what else we needed to do. But in the days that followed, it was, we kept kept tabs on what was going on in China, and it was clear that things actually were evolving. And within a week, we decided that, well, we're going to have to turn our attention actually to this particular virus, and really think about planning specific for what was going on in China, even though it had not reached the U.S. And within 2 weeks, we had launched a full-fledged group and meetings focused on preparing for the eventuality that where there was an outbreak not only in the U.S. but specifically in New York. The reason that this is important is that now we're at the end of January, almost at the beginning of February, and we're already in full preparation mode at that point, even though we did not have a single patient yet in the US or even in New York. So we had some lead time. And we worked on all these different aspects, various plans, how patients actually would move through the system in ED, how we would communicate with not only patients and families around what was going on, whether we had enough supplies, therapeutics, vents, every aspect that we developed, what we thought actually was going to be an appropriate and playbook. The number, as we looked at this and we planned it, the number of patients that we thought we were actually going to get was certainly much lower than what we actually got. And so the fortunate thing for us is that at least we had we had a lead time to prepare. So by the time we got our first patient, which was in the first week of March, we did have a full-scale plan in terms of exactly where we would place patients, how we would handle it in terms of personal protective equipment, supplies that we would use, training of staff, etc. However, the number of patients ramped up very, very quickly to the point where we're scaling up as far as opening up new units and dedicating those particular units just to COVID. We couldn't have anticipated the extent to which these patients came in through the ED and rapidly decompensated. And many of them, in fact, were going to the intensive care unit at a ratio that we have never seen. Meaning, so it was around 50% of those actually were coming through, actually ended up in an ICU, much, much higher than the norm. And so that means that we were actually opening up and had to staff intensive care units. And that aspect of the pandemic, in terms of the volume, the sheer volume, the need to make sure that that staff actually were there, that we had, we were rotating actually individuals, with keeping staff safe, we have enough equipment, and in addition, keeping up with the science as it relates to therapeutics, making sure that we were treating patients with was evidence-based, and that everyone across the system, since we have 3 sites, actually knew what the playbook is actually in terms of what we were using, how to do it, etc. And to give you a sense of some of the specifics that I'm talking about, one point we were observing certain things, such as that patients were developing clots. We had not heard of this before. We had not seen it. It was very strange. And the clots actually were in different organs. And we had to make a decision as to the approach to what we were looking at and what we were seeing, what we were observing, and anticoagulating, giving these patients actually blood thinners. And the question actually is, well, how much blood thinner do you give? At what point? What are the parameters? And so we were making observations, making decisions, therapeutic decisions, very, very quickly, and we didn't have a lot of data, to go with. We didn't have a lot of trials to say, okay, this is the way that you would approach it. So in many regards, actually, like what we were doing actually is the speed at which we actually were doing this in terms of learning things and adapting far quicker than anyone actually had ever seen. At our peak, we had converted almost the entire hospital into a COVID hospital. Part of that decision was out of our hands because what we were also adapting to were regulations from the state. And at the point at which they made the decision that we were going to stop elective surgeries, then we were able to shift certain resources and use those particular beds for patients actually who were coming in. And that was a very significant thing for us, and to be able to accommodate the volume. Post-pandemic, since, we now, I would say we are still in the pandemic, but after the wave, we are still taking care of about 30 patients throughout the entire system. And we have recovered in terms of starting elective surgeries and taking care of patients who are coming in for other reasons. And that was important because many, many patients delayed their care during the pandemic. They were afraid, they did not want to come in. And so we tried to make adjustments in terms of using virtual visits for patients to at least stay in contact with their physicians. And however, that's no substitute if somebody needed to have a particular procedure, whether it be a colonoscopy or some other procedure. Those that unfortunately were delayed. Now we are in the process, and we continue to do this in a very iterative fashion, in the process of actually preparing what we call actually a second playbook for a potential second wave. And like we did in January, where we had a tabletop exercise, we did not know that it was going to be COVID. We were just practicing on MERS. We had a tabletop exercise specifically for a potential second wave, where the idea is that we have COVID plus the flu, and what would we do? So I'll stop there, Jamie, and we can actually, I'm happy to answer questions and continue the conversation.
Great. Well, thank you, Fritz. At this point, I'm going to introduce the Albion students that will join us for the Q&A. I'll start with Peyton.
Good evening, I'm Peyton. I'm a junior
Hello.
here at Albion College.
Nice to meet you.
I'm part of the Wilson Institute on campus.
Okay. Anna?
Hi, my name's Anna. I'm from Rockford, Michigan. I'm a junior biochemistry major on campus, and I'm also part of the Wilson Institute for Medicine.
Fadwa?
Hi, my name is Fadwa. I'm a sophomore at Albion. I'm from Grand Rapids, and I'm also part of the Wilson Institute.
And Livia?
Hello, my name is Livia, and I'm from Romeo, Michigan, and I'm a first-year biochemistry student in the Honors and Wilson Institute on campus.
Great. Well, welcome to the students, and I'll pass it over to Fritz and you guys.
Great.
I'm here to listen. Go ahead.
So I'll start us off kind of on the topic of patient care. So you mentioned earlier that many patients did delay their care. How much of an impact do you think the pandemic had on these patients that didn't have the virus, who required intensive medical care, and did these patients' outcomes suffer due to the delay?
It is a great question, Anna, and you were right. The pandemic did impact these patients in a number of ways, and I think we're still trying to assess to what extent did this actually did it impact them, and it's hard actually to quantify for a variety of reasons. However, it's quite clear that patients actually delayed care. In terms of preventative care and patients who had who needed treatment and for a variety of conditions were afraid to come to the hospital, or they did not, or they just for a number of reasons, like they didn't want to come in, or we couldn't provide the care. So as I mentioned, the issue of elective surgeries. The definition of what's considered elective, in other words, you didn't come to the ED, it's not an emergency, those cases we would be able to do. However, if you needed a biopsy to assess whether or not you have cancer, that would be considered, well, it's elective, it's not an emergency, but you could imagine what that means to a particular patient. And of course, that delay meant that we couldn't then move ahead with the care. So without a doubt, actually, that it did impact them. And of course, it impacted certain populations disproportionately because of access, in terms of what were the choices available to those individuals, given that the entire city essentially was shut down.
I do have a follow-up based on what you said about different people being affected differently. In regards to sending COVID patients to nursing homes, what would you say the logic behind that was? And did you agree with that decision in the moment?
Yeah. So the question is this issue of what happened, what was the real story actually with the nursing homes? And there was a lot actually in terms of patients actually being sent. And the reality is that that when we looked at exactly what happened during those nursing homes and the outbreaks in those nursing homes, it wasn't from patients who were coming from hospitals who had COVID, who then went into the nursing homes and then affected patients there. but rather it was most likely because of staff who had COVID, who were actually there, and then who actually infected the nursing home residents. Why do I say that? What's the evidence of this? Well, a couple of things. One is actually we look back at the data, we got to do contact tracing in terms of what was going on. Two is that many of the patients who would have gone to, let's say, like a nursing home and who had been hospitalized, their length of stay was so long that by the time that they were leaving the hospital, that they were no longer infectious. And the requirement actually to go back to the nursing home was that you had to have 2 negative tests in order for you to return to the nursing homes. So although that was something that got a lot of play, in reality, that wasn't really the main source as for what happened in the nursing homes.
Great. Thank you for clearing that up.
You're welcome.
For my question, you kind of touched on this during the introduction, but I was curious if you could describe more in depth the evolution of the ICU COVID patients, like your first few admitted, and how you handled that compared to how you handle positive patients that are admitted today.
It's a great question, because I think, Peyton, what you're getting to is that did anything change with the patients that we saw as they were coming in terms of the acuity? What was really different here? It's almost like the natural history of it. And it's a great question because, yes, things did change. Initially, when we were preparing for our first patients in the ICU, we dedicated 8 ICU beds, and single-bedded rooms, air exchange was appropriate, etc. Those beds were filled up very quickly, and your question really speaks to, what was the nature of those patients? They were extremely sick, meaning some of them, by the time they came into the emergency room, within hours, they were intubated. They were, and also, like, when you look at the way in which they decompensated, not only there was probably not only the issue with oxygenation that they had, which was very, very difficult, the issues related to their ability to maintain their blood pressure, and also, as I mentioned before, in subsequent days, actually issues that they had actually with clotting and organ failures. It was rather dramatic. It was quite dramatic for these patients, and many of them, in fact, deteriorated to the point that they couldn't recover, and they died. Over the weeks and months, as we tried various therapies, as we also learned more about the way to deliver oxygen, how we actually were going to address the clotting, etc., we did notice that there was a change in terms of survival. Now, these are patients actually who were coming in. However, independent of what we were offering, we also noticed that there was a difference in how the patients actually were presenting. Meaning, yes, we were still seeing patients who were coming in and they had COVID and they had respiratory symptoms, etc. But it was almost as if something actually had changed where the acuity was different. So that towards the tail end of the pandemic, remember the ratio that I shared with you, that overall was probably at the peak about 50-50 going to the ICU versus acute. There were some days where that ratio was much higher, meaning probably on the order of 75% actually were going to the ICU versus 25%. And towards the tail end, that actually had shifted, where now it had come down and where maybe it was 20 to 25% actually were in the ICU versus acute. Do we understand exactly why that is? The answer is no, not entirely. There are a lot of different hypotheses, but even today, it is rare for us to have a patient who's coming in who tests positive for COVID and who is that sick and that who's going to end up in the ICU. We have a few, but right now, maybe it's we're seeing one every week or maybe every 2 weeks. So something certainly has changed. And so it means that then, and of course, again, I want to separate that this has nothing to do with the therapies and the lessons learned in terms of how to deal with these patients. We're talking about individuals coming through the door. And once they come in, yes, it is true that we were able to offer various therapies. We know how to deliver oxygen differently. We learn, what to do and importantly, what not to do, including the use, not using hydroxychloroquine and azithromycin as a combination for the impact of the heart, etc. So our playbook has been refined. However, most of if you look at this on a population level, there were patients with various comorbidities. There were patients that were very ill. And one hypothesis is that many of these patients who were more susceptible, in fact, presented very acutely, and they were the ones who were more likely to end up in the ICU and unfortunately passed. So, but it is a fantastic question. And yes, we are seeing a difference now.
Thank you for your response.
Sure.
Anything else, Peyton?
No, I was going to ask about what you had learned, but you basically touched on all of that with like the clotting. So thank you very much.
Sure. I will share with you, Peyton, that there are many other lessons that we learned. And I touched on the patient side, but from an operational perspective, there are many things that we learn in terms of staffing models, in terms of how do we keep our staff safe, which was something that certainly many of you actually have read about, which is quite important. So while we're delivering the care, we're taking care of sick patients, how do we make sure that our staff also are doing okay in terms of the use of personal protective equipment? Where would you use the certain equipment? The approach to certain procedures that generate aerosol, so that that would put patients, the staff at risk. All of those that we were important lessons learned. A very specific example that I can share with you is that we developed a technique at our institution to do what's called a tracheostomy, so that if patients actually who have been intubated and we know that they're going to be in a while, so instead of putting the tube, we actually would create the trach. The way in which we approach that procedure reduce the aerosols that would be generated, and therefore was more likely to keep our staff safe. It was also safer for the patients, and the outcomes actually were better. And we've published on this, and that was an important lesson learned.
Thank you very much.
You're welcome.
I think Fadwa had some questions, but I think they probably were answered. Anything else on this topic? Maybe Livia, if you have.
Yeah, absolutely. I had a question about the ICU, and I was wondering, what were some of those major issues your faculty ran into regarding safely admitting both COVID and non-COVID patients, and how you keep your ICU safe enough to hold both that large number of COVID patients and those admitted with other medical issues?
Sure, it's a great question. And to put it in perspective, prior to the pandemic, our medical ICU had 18 beds, total. And at the peak of the pandemic, we probably had in our ICUs alone somewhere closer to 150. What that means is that we had to have dedicated units for COVID, and that happened really, really quickly. So the issue, and you raise a great point, is that, well, then how do you do this where you have patients who don't have COVID versus COVID? The answer is that we didn't mix them. We had dedicated spaces. So we said this unit is a COVID unit, and all the beds and everything else that's going to happen is going to be for COVID patients, and other units actually were non-COVID units. Initially, our plan actually was that we thought if the numbers actually weren't too high, that we would be able to have, let's say, a dedicated ICU for COVID, a dedicated unit, non-ICU for COVID patients, and then we would see how things played out. However, very quickly, the numbers actually increased. And in addition, because of the decision by the state actually to suspend elective surgeries, it meant that we had more space. We had the ability then to convert additional floors as dedicated COVID units. And therefore, we didn't really have a situation where we had the mixed units of those patients. The staff actually shared your concern initially, because then if you had those mixed units, it means that on one particular room, you would have to don everything and use PPE, but the next room, maybe you didn't. So how does that play out? And so there was a lot of concerns in terms of then those protocols and those workflows. By dedicating the units, it really avoided a particular issue. After the pandemic, or after the wave, I should say, we did convert to units that had mixed, meaning that they weren't necessarily dedicated to COVID alone. However, the numbers were so small, where you only had one, let's say, in a unit that had, that might have like 20 or 30 beds or so, that it was very, very clear to the staff, and you could have dedicated individuals actually to take care of those patients and appropriate workflows. So it wasn't as much of an issue.
Fritz, I have two questions from the audience.
Sure.
One is, did you or your responding team see a change, and I think this is with the staff, in the physical, mental, and emotional state as the pandemic continued and more ill patients were admitted, and what kind of support was provided to address this?
So it's a great question, and the short answer is yes. This was probably one of the most challenging times that we've ever faced as a staff, and for a number of reasons. And to just share a few of those reasons, one, it was the uncertainty of what was to come. If you can imagine what I shared with you in terms of the story, like where initially, like we were preparing, and as we got the news, we probably had the benefit of that. Because of the benefit of the tabletop, we had some lead time. Nevertheless, you're not sure exactly how bad this is going to be. What is the wave going to look like? And so there was a lot of anxiety as far as how this actually would play out. In addition, there was also the concern about once the patients actually started to come in, how, what would we do? Like, in other words, how would we handle it? Are there things that we couldn't anticipate that we would have to deal with? And the answer to that actually was yes, meaning it is difficult to prepare the staff for the amount of illness and the speed at which some of these patients, in fact, deteriorated, where we were, the codes that were being called and how quickly, that happened, the number of intubations, like serially, like even the ED, like almost like, we're lining up the intubation boxes. It's really, really difficult actually to prepare. You just can't prepare for that. And seeing what was going on in the units themselves and how the things actually were happening. Again, it's hard actually to prepare for that. And so we did have services actually available for the staff, not only to support them in a variety of ways in terms of mental health and counseling, etc. But quite honestly, there was a lot of if I think to not only the trainees, the nursing staff, etc., there was still a lot of issues that they were actually dealing with or confronting in terms of just trying to wrap their minds around that experience. And quite frankly, I think that it is, to a certain extent, it's still happening with some of with many of the staff, because it's one of those things where you can't forget it. I mean, it's an experience, and to say that it didn't leave an impression would be disingenuous. So it had a significant impact. We have done this, and we have ramped up working with our, with various teams in the Department of Psychiatry to provide a number of various resources in a number of ways actually for our staff, but certainly in terms of what they have communicated to us, which they've communicated directly to me in talking to them. This was quite impactful, and to give you a sense of some of the things that I've heard. the families of the patients couldn't come to the hospital. And you can imagine a young nurse at the bedside. We tried to use technology and iPads to connect the patients with their loved ones. But there were moments in which that nurse who was there at the bedside in person with that patient holding that iPad was there so that the family would say goodbye one more last time. And you can imagine the impact on that nurse and the staff. And that happened a lot. We developed a program that's called Family Connect, where our medical students, as well as other attendings, volunteered to communicate what was going on to the families, because the teams, let's say the ICU team, was so busy and the work was just so constant that it was hard for them to then be able to go and take the time, like hours, to kind of go through everything with the families in the way that they would normally do it. And so having that group dedicated to literally communicate with families was very, very important. And they did that, and the families actually appreciated it. But it gives you a sense of all these different operational pieces that we try to put in place to help the staff and the families, quite frankly, because they could not be there. And that human connection that was missing, like that in person, was something that impacted both, not only like families, the staff, and also clearly actually the patients.
Why don't we move to policies and protocols? I think, Peyton, you're going to lead us off on that.
Yes, so my question was, with all the rapidly changing information that the World Health Organization and the CDC, along with national and local governing bodies, are coming out with, I was just curious how you and your team approach those, and whether like you see the need to immediately cause for protocol changes within your location, and how you like address that with those that you work with.
So that was a challenge. It was a challenge because what we were trying to do is not only stay ahead or stay on top of some of those regulations and protocols that were coming out, but reconcile that with what we needed to do on the ground, the realities of the ground on the ground. So let me give you an example. Early on in the pandemic, there were very strict criteria for testing. Testing was not available actually at the sites themselves. The hospitals couldn't test. They actually had to send those out. But there were very strict criteria. So you could have a patient come in to the emergency room where the pretest probability was very high, and you knew that maybe this patient should be tested, but you couldn't do it because they didn't meet the criteria. Or you would call and you said, well, you know what, I think this patient should be tested. And you would call actually the Department of Health, and it would say, no, we don't think this patient should be tested. So what do you do? As a physician, that was very, very hard. So it's an example where we understood why, because obviously, the amount of testing wasn't widely available, and so they had to be very selective. Nevertheless, there was the reality of what we needed to do on the ground for the patients here, and an understanding actually that it was impacting us. There have been a number of policies, including I was just talking about what we tried to do to connect families. So the visitation policy was a challenge in terms of how to approach that and what we do. And of course, it wasn't from us, but rather this is the policy. This is what you had to adhere to. And of course, I could go on and on. Actually, there's a travel policy, et cetera. And what happened actually was that we would look at there was the CDC, the state, the city, and at times they didn't really align. And we were trying our best to ensure that we were following these particular guidelines while doing what needs to be done for our patients. And I'll give you another concrete example, that there were guidelines around if a staff member had a particular exposure, how long would they have to be out for, out of work. Well, the problem with this, as you could imagine, is that now you could have a certain number of individuals, because the rates actually of positivity in New York was so high, that you'd have many of your staff actually would be out for 2 weeks, let's say. And how do you backfill that? And what do you do? Because you have to care for the patient. So there are many of these actually that impacted us, and we tried to reconcile. And at times, actually, we would try to communicate this concerns to the state. We, in fact, there were in New York, the chief medical officers of the various systems were in touch with one another, and we would get on calls and talk about some of these issues and try to the best that we can to communicate these types of concerns, to try to influence these changes. Sometimes, it worked, where it's like, okay, we're going to make this particular change, and sometimes it did not. And unfortunately, some of the other regulatory bodies were not able to move as quickly as we were able to move, meaning we were seeing things in real time, say, okay, this is what we need to do, et cetera, but we simply could not. So it is a challenge. It has always been a challenge, and I suspect that it will remain a challenge in terms of those bureaucracies, and how do you implement policy and making sure that things are done in a certain way, and how do you translate that from an operational perspective based on the realities on the ground.
Anna?
Thank you for that.
Sure.
Yeah, so my next question is a little bit of a different topic, but the pandemic has shed a light on a lot of socioeconomic disparities in many different areas, but a big need for equitable access to healthcare has become, I think, one of the more pressing issues. Moving forward, how can we ensure that patients at underfunded hospitals receive the same care as hospitals in wealthy areas?
So it's a great and a very important question, Anna, because one of the things that the pandemic revealed is that clearly there were differences in the prevalence of COVID actually in various neighborhoods and various populations, and we saw that. However, patients actually could walk into any emergency room, and they did, because of proximity to where they live, et cetera. Once the patients actually came in, however, then we were able to care for them in a manner that was not different. In other words, it was the same. So your point about access is really the key here. And also dealing with what's happening in the communities. So what I would submit to you is that the key to this is not just what's happening in the hospital. You got to go upstream and think about the community. Think about what is it that we need to do to ensure that these communities actually are being cared for appropriately, so that we're not getting to the point where they have certain chronic conditions that need more urgent care, et cetera, because we know that many of them, unfortunately, will get try to get that care in emergency rooms, et cetera. The evidence for what I am saying actually is something that we experience ourselves, in that when we looked at our data, we saw that, in fact, looking at the number of the patients who are coming in through our emergency room, all comers, that the prevalence of COVID actually was highest among Black patients. Now, and that's consistent with what others actually have seen. However, for those patients actually who were hospitalized, the number of those patients, of Black patients who ended up in the ICU, was lower. Number who died was also lower compared to Black patients. So what does that teach us? Again, it emphasizes what I was saying before, so that the issue really is that we got to go upstream. The individuals have a chance to make it to the hospital, and you have a system that is able to deliver that care and has all the resources, et cetera. And yes, we can actually do that. But the problem doesn't start there. You cannot solve it there. You got to think about then what were the what were the issues that needed to be addressed to make sure that the prevalence actually is lower. You think about housing issues related to housing, etc. It's really, and we haven't appropriately dealt with those sorts of issues, and that then combined with making sure that all those hospitals actually are appropriately resourced, then will address exactly what you're asking.
Thank you for your insight.
Tuesday, we had Zeke Emanuel on this series, and he talked to us about rationing the potential vaccine and how should we stratify that. And there have been some very recent policies that are being considered. He actually argued that the infection control measures that you and others have put in place for healthcare providers are so good that there isn't an increased risk in that setting, and that they should be deprioritized with respect to access to vaccines. And I thought it was a provocative
it is.
comment, but I wonder what you think about that.
Yeah, it is actually a very provocative comment, and I can share with you that just earlier today, this topic came up in the context of thinking about where we are with vaccine trials and who should get it and how we can we should prioritize. And one of the things that came up was that well, yes, the healthcare workers should be prioritized because they're in the front lines, etc. And if we follow that logic, the issue is that has to do with the exposure, meaning the likelihood of exposure versus somebody who's, let's say, who's not in healthcare and has a different. So when you then think about the risk, it is certainly higher. Zeke actually is correct. What's remarkable and what has happened is that because we put in place various protocols, and if people actually adhere to those protocols in terms of personal protective equipment, it works. And what we were concerned about in terms of saying, well, frontline workers actually might get infected, and many of them actually are gonna die, etc. Those numbers actually were not, knock on wood, actually as high as one might have expected, but it was far from zero. The truth is that healthcare workers were impacted and they died, and that remains a concern. And so I would submit to you that while it's an interesting proposal, that those workers are still at very high risk. And it's important actually to make sure that we do that they get vaccinated. That for two reasons: not only for themselves, but also the risk that they pose to others. Not unlike the flu. So if you think about what happens actually with the flu and why it's important for me, like I got my flu vaccine this week, and why did I do that? Well, even if I think, well, maybe I'm going to get the flu and it'll be mild for me because I don't have, I'm relatively healthy, etc. But what risk do I pose to others? Every time I run out, I might see how many patients, and I'm engaging with others. Who else am I exposing? And the reality is that there were, during the pandemic, we know that there was clusters that happen because of healthcare workers. Mm-hmm. So it's not only the risk for themselves in terms of protecting them, but also the fact that they could expose others.
One other question from the audience, and then we're going to end on crisis prevention or preparation. Mm-hmm. The question is, how does the hospital and your practices, probably more outpatient as well, respond to the flood of patients who have become overly concerned for their health over the slightest symptoms due to anxiety towards COVID-19?
Yeah, so it's not only it's a great question, but it's one that we wrestled with before we ever had a single patient in the hospital. And remember, I said to you that we launched the group got together actually after when we realized what was going on in China after our tabletop to say, okay, now we're going to start planning, and we're going to start thinking about what we're going to do, and we're going to think about this in the context of what's going to happen in the emergency room, what will happen on the inpatient side, et cetera. And one of the things that we talked about was that we were concerned that our emergency rooms would be flooded with what we call the walking well. Individuals who really weren't sick, but they were so concerned that they would come into the emergency room to say, I think I have COVID, et cetera. So what do you do? So what we did is that we ramped up our virtual urgent care, where we made that available as an option. And we really publicized that a lot. And we sent out information about the availability of virtual urgent care to all our patients at Albion, and it was on our websites, et cetera. So it meant that to somebody who was concerned, you could be at home and say, well, I'm concerned and I'm debating whether I should go to the emergency room or think about it. Say, well, before you come, you can literally pick up your phone and you can set a visit and using your phone or iPad, you can have a conversation, you can have a visit with a physician and you can go over that for you. And if you need to, then yes, you'd be directed to the emergency room, et cetera, or you make a visit in other fashion to the office. But I will tell you that that was a very, very important strategy for us, because the vast majority of those virtual urgent care visits were in fact for those types of patients. They were fine. They didn't really need to be seen in the emergency room. And so without that strategy, I think we would have been flooded.
Great. Fadwa, I'll pass it over to you. You had a question about crisis preparation.
Yeah, so in your introduction, you touched on crisis planning, and I know that following Hurricane Sandy in 2019, your team started crisis planning for future events. Which parts of your planning do you think were most useful to implement during the COVID outbreak?
That's a great question. I think when Hurricane Sandy, we had to very, very quickly do whatever it is that we can, meaning that, we had to evacuate and everybody just rolled up their sleeves and did what it is that they needed to do to get patients out. And fortunately, we were able to do this safely, but it was far from coordinated. And the lesson that we learned and that we used for the pandemic was the importance of coordinating in different groups, different areas, and making sure that everybody knows not only what to do, but also the needs. So to give you an example of what I'm describing, meaning if I plan to open up 4 intensive care units, the supply chain team needs to know that and plan to be able to get the appropriate supplies for me to be able to do that. The clinical engineering team need to be able to support those units as well in terms of IT needs to be able to do that. Nursing needs to think about the staffing ratios, et cetera. So in other words, everybody needs to know those plans and start working on exactly what they need to do. The coordination is important. The training, because we can't just flip a switch, because there are individuals, in fact, who hadn't taken care of those types of patients well. So how do you train individuals to do that in a timely fashion? Even training individuals to put on personal protective equipment was deliberate. Jim was talking about, well, yes, we did a good job with it in terms of our healthcare workers. That's why we kept them safe. But it's not luck. There is a way actually to do it. So what we learned, Padua, was that the coordination and the communication is so critical. And that actually cuts across any crisis. We have practiced for active shooter. We've practiced for cyber attacks. We've practiced for hurricanes, for fire, et cetera, and even for birds. And that's a common thread. Do the various teams understand what to do and what the plan is? Because you can't, without that, then you get, this organization. I could say to you, yes, I'm going to open up 2 units, et cetera. Oh, but we don't have any supplies, or we don't have enough nurses, and therefore it's not going to work. And I think this is one of the key things that allowed us to very smoothly and very quickly be able to open up in units and transform an entire hospital in record time and do it safely and effectively. And I think that was a very, very important lesson learned, not just from the pandemic, but from Hurricane Sandy and crisis management.
Livia, you had a question about supply as it related to ventilators. Maybe you can.
Yes, I did. So how are shortages in ventilators for patients managed? And have you worked with other companies or businesses to build more of these ventilators in order to ensure the lives of patients who are in need of that assisted airflow?
Yeah.
And
So yeah, what's interesting about that question is that there was a lot of news and about ventilators, but we thought about it differently. It's not about ventilators. It's about how do we deliver oxygen. And if you think of, and if you shift that and you say, well, it's not, the issue is really not the vents, but rather oxygen delivery, then you realize that there are other options. And the truth of the matter is that there are other machines that are not quote unquote ventilators that can deliver oxygen to patients depending on needs. So we can deliver high flow oxygen. There are machines that deliver what's called a continuous positive airway pressure, they can keep that airway open and deliver the oxygen. So we actually thought by framing it differently and thinking about how we might actually deliver the oxygen, besides using a vent, then it meant that we had more at our disposal. And not every patient needed actually a vent right away. We were able to support some of these patients with high flow, et cetera. And we did not run out of ventilators because of that, because of the strategy that we employ. Nevertheless, we also did communicate with various companies who were building new machines. And we ended up, so it was actually, to be honest with you, on the tail end of the epidemic. We didn't really need them. It wasn't like urgent, but we nevertheless got delivery of some new machines that worked well, and they were advanced. And that kind of helped because we wanted actually to test them out. So much so, and as Jim actually mentioned, I ended up when I went to the White House, the program that many of the hospitals actually had, the hospitals actually came together to say, we can develop a vent sharing program. Meaning we're doing fine, we had enough vents, but maybe if this particular hospital or another state, another area, they don't have enough, can we lend them our vents? Because they're just sitting there. And the truth is, our vents actually were just sitting there. We weren't actually using them. The other thing that we did do is that we created a policy, just in case, it's almost like just in case, we created a policy as to how we would allocate vents should it come down to it. Like if it really was a dire situation where now you have patients coming into the ED, you're down to your 2 vents and there are 10 patients, how do you choose? And so we did have those criteria. We never, thank goodness, we never had to use it. But we didn't want to wait and kind of say, okay, this is like something that we haven't thought about. We thought about it. We really did. So it was about the way in which we would deliver oxygen. We explored other possibilities. We had a policy in terms of allocation that we didn't have to use. But that was our approach.
So Fritz, I think we're going to ask you to conclude, and maybe you can give us a little preview of what we're going to hear on NPR about the next surge. Is there going to be a next surge? And if there is, how not only you, but we should be preparing for that?
Sure. So here's what I can share with you. So what we have been doing is working quite actively to think through all these wonderful questions that all of you have asked. And it's as if you've been in the rooms with my team and really, poking at this and challenging each other actually to say, well, what did we miss here? And we thought about the challenges, the lessons learned, and we created, a playbook which is probably over 70 pages long, with all the details that you can imagine, things that you haven't even thought about, like from therapeutics to equipment to staffing, and really map this out with the idea that if there is a second wave, what we were concerned about is not only COVID, but also the flu. I think it was actually Peyton that asked a question about, did we see a change in the patients? And the answer is yes. So what's fascinating, what I can share with you, Jim, is that the natural history of the virus seems to have changed somewhat. in terms of how patients are presenting, which is actually good, meaning we are seeing patients who are coming in, they might test positive, but they're not as sick as we were seeing earlier on. That's a good thing. Second is that overall, we also know that many patients have probably already been exposed, and therefore, even if they test positive, they're not coming in with primary COVID. They have, that's not an issue for them. Third, actually, is the issue with the flu, which we're very concerned about, and we've heard about. In other words, the confluence of COVID plus flu. But here's the fascinating thing. If you look at what happened in Australia, which usually they have an earlier season than us, and we can learn from them, they did not have a flu season. Think about that. Part of the reason is precisely some of the things that we talked about today, which meant that some of the steps that were taken, meaning that people are wearing masks, they're social distancing, etc., you are less likely to pass on these viruses, including the flu. So what we think is happening, and early signs even in New York, is that we are not detecting influenza in the same way that we would actually expect. So fingers crossed that maybe we're not going to have as big a wave as we expect, however, that everybody's anticipating. However, we are doing our best to be prepared. That's what I can share with you.
Well, look, I really appreciate you taking the time today. And, we as a nation watched the entire country go through this pandemic, but what was happening in New York City was just incredible. And the heroism, not only there, but beyond, was inspiring, and really appreciate you sharing your stories with us today, and Godspeed for what else we're up for. And thanks for the students for your questions as well.
Oh, my pleasure. And it was really, really enjoyed all your questions. Thank you so much for inviting me.
All right. Well, thank you. Everyone have a good evening. Appreciate it.
All right. Bye-bye.